Welcome, Professor Mike Millis.
Thank you very much, Klaus. It's a pleasure, an honor to be here among longtime friends and new friends. Hipology 2020, Philosophy, Science, and Craft. So difficult to know what to say to such an interesting and interested group of people. I will begin by disclosing and apologizing. The fact is, this lecture is a work in progress, and my wife knows up until the very last minute it's been a changing thing. That's what happens with PowerPoints these days. So this is viewed by me as a dialogue with all of you. This is a dialogue, a continuing dialogue, and I hope will continue responsively today, tomorrow, and after. So I have 20 minutes, maybe thanks to Richard Santore's begging for me a few more than 20, but more or less 20, 40 plus years of practice, and 76 years of life. This is inevitably an incomplete look and incomplete reflections with deep regrets regarding those many people important to me in hipology who are in my thoughts but not named. So this is personally rewarding, unquestionably, and it's frightening. It will be paced rather fast to fit the constraints, like our digital world, yet it's based on people and relationships and ideas whose value is really best appreciated, not by talking fast, but by thoughtful pondering. So these are more disclosures. I am a hipology zealot. You know, I am passionate about hipology. My first childhood memories were indeed when I was only 2.5 years old in Iowa City, where my father was an orthopaedist, a friend of Ignacio Poncetti, and my father was a Santore fellow. So from the onset, I've been an admirer of the Iowa orthopedic tradition. I've been blessed with a deep interest in the natural history of patient outcomes, honest and careful patient data collection and analysis, and I've been very fortunate to have a career-long single-site practice, which has allowed me a continuity, which has been very rewarding. Many people to acknowledge. I'm not going to read all the names, but I've had classic teachers, those who have taught me and others. There are basic researchers, including Henry Mankin, one of my important teachers recently died. Great joint-saving surgeons, many of whom are known to all of you in this room. Mentors, including Professor Gans, Professor Hall, Professor Harris, and Professor Wagner, and many colleagues, particularly those at the Children's Hospital Hip Unit, but many others, not only here in Switzerland, but around the world, particularly the Anchor Group, supportive chiefs, and our patients, and indeed our families. For me and for all of us, there are sources of wisdom far beyond physics and surgical orthopedics. Here in Bern, it's easy to think about Albert Einstein, who said information is not knowledge. The only source of knowledge is experience. You need experience to gain wisdom. Well, if I've gained wisdom, it's to a large degree from my patients. And these are some of my patients. This says, don't judge my path if you have not walked my journey. And indeed, none of us, except those who have been hip patients, have really walked the journey. But we can really learn a lot from our patients. So why are we all here today? Thank you, Paul Boulay, for this picture, which was a faculty gift in 2001 when I was on that first faculty in Quebec City. We have shared special interests, indeed. Some might say shared passions. Our spouses might say shared obsessions with the hip and how to make it better. So there are some important discussion framers, and for me these include important people, connections and relationships, and ideas. And it's my privilege and responsibility to honor our field and to honor those to whom we owe so much. Homage to Bern, of course, center of higher learning for centuries. Theodor Kocher, first Swiss surgery professor in Bern, an Anglophile. He spoke English and French fluently. He had many visits to England. He won a Nobel Prize. But interestingly, he hosted many international and U.S. visitors in these early days of the 20th century, including Cushing, Kreil, Halsted, Mayo, and many others, as Professor Müller, Professor Gans, and Professor Siebenrock have done much more recently. we acknowledge, of course, Professor Ganz, who had a world-changing influence on hip preservation. And these are pictures of some of the people who visited Bern and who have taken some of Bern back to their individual places as far away as the west coast of the US, Miyazaki, Japan, and Adelaide, Australia. So Bern is indeed an Athens of hip preservation, if you will. Many great people have worked here and still do. So hip preservation, in terms of connections, is truly global. In North America, early on, this was AO-driven. There were courses at Davos that attracted many Americans. And in the late 1970s and early 80s, John Wedge, Bob Poss, Mike Millis, and Richard Santore were privileged to do AO fellowships to Bombelli, and Bern to see Professor Ganz and Professor Müller, and I to Germany and Heinz Wagner. Well, what about Japan? I sort of came a little bit late to understand the importance of Japan in hip preservation. But indeed, there have been major contributions to hip preservation for many, many years that were not well recognized in Europe and North America, particularly at Kyushu University and in Tokyo, where recently Professor Nakashima introduced me to details about Nishio that I did not know before. And of course, the name Sugioka is well known, as is Tagawa for RAO. So this lecture, to some degree, is dedicated to the memories of these great men. Professors Müller, Salter, Mast, Sugioka, Tonnis, Wagner, and Bombelli. And indeed, Sugioka has written a lot about osteotomy as regenerative medicine. His work should be written, and a lot of it is available in English. And Bombelli, as Richard Santore told us, only last week at age 97, Renato Bombelli died, giving generations of orthopedists important information and insight into the structure and function of normal and abnormal hips. Great books, great concepts, they should be read. What's hipology anyway, this funny made-up word? Well, for me it's a science. It's the study of the hip and its disorders, but even more important, it's a study of the patient affected by hip-related disorders. It's a recognition of the complex systems in which the hip operates and works. It's a philosophy, too. It's a respect for preservation of the native hip. It's a respect for function with a broad biopsychosocial perspective extending beyond the hip. So clearly mechanical function is very important, but not the only concern. And of course, it's a craft. Hip surgery is a powerful tool with risks and benefits, with biological aspects and technical mechanical aspects. Hipology is people. Salter and many others. Robert Salter. The concept of acetabular redirection really began with him in the 50s. He had an incisive wit. He also invented CPM. One of his great quotes, "No operation is foolproof because fools are so ingenious." He also said, "Don't be a Christopher Columbus surgeon, because when Christopher Columbus sailed for the New World, he did not know where he was going. When he reached the New World, he did not know where he was. And when he returned from the New World, he did not know where he had been." Professor Dietrich Tonnis, perhaps most known around the world for triple pelvic osteotomy, but his insights on the importance of abnormal version in mechanical hip dysfunction should also be recognized. He had a classic current concepts article in the Journal of Bone and Joint Surgery in 1999. Read it, please. Classic text, Congenital Dysplasia and Dislocation of the Hip, now available, again after many years out of print. Buy it and read it. And Reinhold Ganz. So many things to talk about regarding Professor Ganz. Some of his many contributions are here, and many of us are recipients of his great insights and teaching. So, what about connections? Well, Iowa, Toronto, DuPont, and Boston in the US were early breeding grounds for major national and international cross-pollination in pediatric orthopedics. And Bern, Fukuoka, and Tokyo were similar for mature hip preservation. So how did I get here anyway? Well, lucky John Wedge, Poss, Santore, and Millis. In 1972, I was a junior resident, and Dr. Salter and Dr. Hall were doing adult anomalous osteotomies in Chiaris. I was just a junior resident, falling asleep there in the back row in the amphitheater at the Mass General Hospital after a night on call. In 1974, my life changed because Heinz Wagner visited the US in Boston for the first time. And Professor Hall turned around to me and said, somebody should go to Europe and learn about those things. And so finally in 1978 and 1979, a group of us were lucky enough to be able to travel to Europe to learn about these things. And in 1981, the first dial-osteotomies were done in Boston. In 1983, several of us first taught AAOS hip osteotomy instructional course lectures. From 1984 to 94, there were Harvard hip and knee osteotomy courses with Bombelli and Coventry, Gans, Morsher, and Wagner as faculty. In 1991, we began to do the first PAOs in Boston, and ever since, hip preservation has boomed for children of all ages. In 1978, 79, and after, these were the years when some of us were privileged to go to Altdorf and Busto Arsizio and Bern to learn these wonderful techniques and philosophies. Heinz Wagner, a very interesting, very complex man, one of his quotes, "The average surgeon is an average surgeon." Not every problem has a solution. Sophisticated operations are for sophisticated patients. But he believed that some of these patients could be taught and could have successful, sophisticated operations. A failure to plan is a plan to fail. Restore function, and bone structure will take care of itself. This is a principle from Wagner, a 10-year-old male with Perthes disease. This is low-tech, old surgery without surgical dislocation, without femoral head reduction. Pain with walking, right leg functionally 1.5 centimeters short, right hip abduction limited, better rotation and no pain in adduction and extension. This patient had a flexion valgus osteotomy. By eliminating the impingement, it allowed tremendous bone remodeling and reduced the subluxation. Luckily, I restored function, and the bone structure improved as well. So this was the world as seen from Boston in the 1980s. This is a picture of young me, Morsher, Hall, Wagner, Tom King, and Bob Poss at an early osteotomy course. This is a poster from a later osteotomy course with Reinhold Gans with his mustache there in the middle, and Millis with some hair, and Murphy with some hair also. Very different now. So in the 1970s and before, hip osteotomies were felt, hip deformities were correctable, but not a real issue in the mature hip. And in the 1980s, people became aware that hip dysplasia was an issue. And in the 1990s, people began to be interested in the interior of the hip. And the acetabular rim syndrome by Klaue, Durnan, and Gans is a classic article which should be read. What was going on inside the hip? Well, Reinhold Gans and his colleagues here in Bern worked it out. And their work on the anatomy of the medial femoral circumflex artery is taken for granted by young surgeons today. But this was very new, very important information years ago. By 2010, femoral acetabular impingement was everywhere. Everywhere, people thought. And indeed, a very important symposium by colleagues, including Dr. Kim, Dr. Clohessy, documented this in a very important symposium. A few years before that, the Bern group wrote a very important paper. Martin Beck was the first author. And a very important commentary was by Richard Field that described hip mechanics this way: instability versus impingement. The human hip represents an uneasy compromise between the need for stability in a joint that transmits loads of several times our body weight and the need to provide a movement. And any geometric restriction has the potential to cause damage. And indeed, we live by these principles today. What about connections? Very important. The Anchor Group has been an unbelievably important connection for me and for my colleagues with critical prospective studies, protocols, assessment tools, powerful networking, and collaborations. John Clohessy has been the lead in that, and we're all better for our experiences with the Anchor Group. So putting it all together, Simon Stephacker said, "I hope I get to see a few smiley faces." Here's Simon, there are a few smiley faces. This is a happy hip in the green zone. These are the way the patients come to see all of us. They're not happy, their hips aren't happy, but we have to figure out why they are not happy and how to make their hips and the patients better. Understand interventions as being vectors. Now, we have powerful opportunity to institute vectors, but we have to make sure the vectors are pointed in the right direction and the right amount. This is very important. So after 2010, we knew that FAI was everywhere, but it became clear that the symptoms were not always correlated. There were other important factors in outcomes, expectations, and among other things. And Anne Mannion helped us understand some of those things with important expectations, outcomes work that she and M Perthes documented, that there are important patient factors beyond the musculoskeletal symptom. Because this article documented that fulfillment of patient-related expectations predicted the outcome. If you improve people, but not as much as they expect, they may not be happy. And so this is another factor you need to consider. Well, what about ideas? I was trained originally as a pediatric orthopedist, and I was taught to believe, and I still do, that in some ways pediatric orthopedists hold the keys to the kingdom because developmental deformity is associated with much or most of adult hip OA in North America, Europe, and Japan. This is important work by Jim Aronson in 1986 that documented in the US for the first time that hip dysplasia was probably the single commonest cause of hips ending up with total hip replacements due to OA. As we fast forward to 2020, now we know that impingement is a major factor too. But the bottom line is, in many of the hips that wear out, these are theoretically preventable problems, and we should be looking for them early in an opportunity to prevent osteoarthritis of the hip. Anatomy. Not enough time to talk about anatomy except to say that the future is continuing interest in anatomy and more computer power. Mechanical function and dysfunction systems, just not enough time to talk about it, except to say that we understand now that instability and impingement are the major mechanical pathologies. In the future, we have to ask ourselves, what are the complex pathomechanisms beyond instability and impingement? And how do we get there? It's not magic. Just as always, it is keen observation and continuing questioning and investigation. Because there's a bioregenerative aspect to hip treatments that is recognized but still not understood. The optimal perioperative and postoperative programs are not well known. The fastest return to play is not a perfect metric for success. And I agree with Richard Santore, having the patient leave the hospital on an outpatient basis after a PAO is dramatic and wonderful, but her program after that is going to be very important for how well that hip does in the long run. And then there's the biopsychosocial stuff. As now, patient perspectives are becoming recognized as important. And in the future, patient-centered teams of multidisciplinary experts are very important to have in place. Well, what about the surgery anyway? This is the Bern Hip Symposium. It's about surgery, correct? Well, yes, surgery. We love this. We do. We're interested in crafts and techniques, analysis, decision-making, preoperative and perioperative factors, and the surgery. But notice, surgery is number 4. It comes after you correctly analyze the problem, you correctly make a decision who should have the surgery, who shouldn't, perioperative things, and then the surgery. So, decision-making. What are things like now? Well, the surgeon still guides the process. Where do we need to go? We need decision-making aids to improve shared decision-making and improved peer support for the patients and the families. Perioperative, psychological. What do we know about the psychological aspects of the disease process? Not as much as we should, and in the future there will be more focused education and patient training as well as surgeon training. Execution, technical aspects. Education, that's what we're all about here in Bern, investigation and education. In the US, there are centers of excellence for hip-preserving surgery, but there's still much variability in technical skill. In the future, more subspecialization, robotic surgery, less variability, better planning, that's what we hope. Well, now we have surgical skill. It's always going to be important. It will never be less important. But now there's an increasing knowledge and that now recognize complexities demand additional skills because the issues that affect our patient outcomes are not only technical. I was asked to give an interesting talk, Becoming a Hipologist, Why It Is Important to the Field. Ira Results, thank you for asking me to give that talk because the rest of this few minutes is about that. What is a hipologist? It is someone concerned as much with questions as with answers. That person embraces and accepts ambiguity and complexity. That person is an early adopter of the concept of patient centricity. That person enjoys shared decision-making, understands the biosocial model of disease, and believes in the power of teams. And that means I am often conflicted. This is a difficult job to have. How does the virus strike? Well, there's the appeal of renowned surgeons. And there are many renowned surgeons in this room, mentors. There's an attraction of hip science, because the hip is indeed a fascinating organ system. Here we all are. We are all attracted by cool hip surgery, because indeed, hip preservation surgery is awesome. And there are usually combinations of all of the above that have attracted us, how the virus strikes. How do we become great? How do we become great hipologists? You have to be a true believer and advocate for the native hip and for the patient with a hip problem. You have to commit to never-ending learning. You have to collaborate. You have to have mentorship. Have mentors and be a mentor. And these are some of my most important ones. How do we advance our field? We learn individually and we collaborate, but not just with orthopedists. I repeat this slide again. Learning about the important patient factors beyond the musculoskeletal system demand collaboration with others who are not orthopedists. We embrace the complexity of the problems presented by patients with mechanical hip problems. We have to be excited by these challenges and skillfully analyzing and surgically treating these problems and these patients. Because what's the reality for the patients? Well, whose reality is it anyway? This is a very short book. You can read it in a couple of hours, even if English is not your first language. It's called The Trouble with Reality. And it talks about die Umwelt versus die Umgebung. No time to talk about the differences, but Chit Ranawat said an important thing: the eye sees only what the mind knows. And what we see as orthopedists is not what the patient sees or experiences. And the truth is somewhere in between. Thinking Fast and Slow, another book that is important to read, because we surgeons tend to be poor listeners. We surgeons tend to be decisive. We make our decisions quickly. Pattern recognition often is dominant, but thinking fast can be dangerous in hipology and in life in general. Daniel Kahneman wrote this book called Thinking Fast and Slow. It's a truly great book. He won the Nobel Prize for this work, and you should read Daniel Kahneman's work. This is one of my most important teachers, this patient, who at 38 years of age had had a triple osteotomy done at age 25. She is massively retroverted. She has a large cyst in her left hip. The hip is subluxated. This is a hip in big trouble. Now she had labral symptoms, good motion, but an anterior impingement sign. This was a real problem. Well, for a number of reasons, I decided that this was a hip worth saving. Lots of work on the left hip and later on the right hip. Well, after a lot of work, a lot of years, she's now 61 years old, 23 years after her left PAO, 22 years after the right PAO. She has no symptoms. She jogs, she skis. A lot of reasons why this succeeded, and I learned a lot from this particular patient. So there are numbers you can read. There's literature you need to know about, but the numbers only tell part of the story. We can read that Professor Ganz's original group, only 1/3 survived at 30 years. Is that good or bad? Well, it depends on how the patients feel things did. And in Boston, at mean 20-plus years, our series shows that more than half of the patients have 0 to minimal symptoms, and more than 20% have had total hip replacements. Is that good or bad? Well, it depends on things that go beyond the numbers. So there are key questions in hip preservation. As I give the last few slides here, you have to look at the whole patient and the situation before focusing on the hip. Clearly, if we are doing mechanical things, there should be a mechanical basis for part of the problem. But we always have to ask ourselves, is the hip preservation the best choice for the individual patient? Well, how do we know? How do we know what's right today? How do we know what's right in the future? There's a concept of disruptive innovation. This is a picture of Clayton Christensen, a professor at Harvard Business School who recently died, and his concept of disruptive innovation is very important. There are examples of disruption, how healthcare is so expensive. The iPhone, the internet, all these things have meant that we as physicians are no longer necessarily on the top of the heap. You have to read an important related book called The Patient Will See You Now. This talks about how the patient now has information that before only the doctor had. So we still have an important function. Only we can do the surgery, and only we can interpret this information for the patients well. So we need to learn to utilize technology, but remember its limits. So yes, we are hip mechanics, for sure. But this below is another elegant machine, far more complex than a Ferrari. And these complex machines have a lot of hip problems. So patient empowerment is one of the things I'm to talk to you about. It can be used positively. Just because we're not the only important thing in the equation anymore doesn't mean that we should reject patient empowerment. There are patient support groups. This is a reality, and we can use these positively. So here's my education in hipology. It's the value of multiple perspectives. The patient's perspective is very important. The patient's expectations, as we found in our work in Boston, is usually not the same as the surgeon's. And hip surgery is a major trauma. Maybe not to us, maybe the incision is small, maybe the surgery is outpatient, but psychosocially, this is a big deal for the patients. Patients are great educators, not only for other patients, but for orthopedic surgeons too. So what can help all on these teams that I think are the way of the present and the future? Empowered patient-centered teams benefit from a hip buddy system, which we've tried to do in Boston. This patient, DB, who had her triple osteotomy a long time ago and her PAOs also a long time ago, since that period of time has mentored me and many fellow PAO patients. It's good for her, it's good for me, and it's especially good for her patient mentees. So HIP 2020 and beyond, these peer buddy teams help to gain better experiences and outcomes for everyone. This is my first RAO patient, my first dial osteotomy that I did in 1981, a PAO in 1996. Here she is in Dubai in 2018 when I saw her on the way to India, and she's still doing very well, but she's doing very well at mentoring others. She's a yoga instructor, and she's helped me teach a lot of patients over the years, and that's been good for everybody. PAO number 1, 1991, at age 38, I'm still learning from her and her experiences, and these long-term relationships are critically important. So these, I feel, are our most important collaborators, the patients who have taught us so much. So we are a hipology community. Here we are, and beyond this room, we appreciate our diversity, we accept, embrace, and benefit from our differing perspectives, so I am proud and lucky to be a hipologist. Thank you very much.